Okay, and joining us virtually next will be Dr. Roberto Romero. He is the chief of the Perinatology Research Branch and director of the Division of Obstetrics and Maternal Fetal Medicine of the NICHD, part of NIH, which is housed at Wayne State University and the Detroit Medical Center. He was trained in OBGYN and MFM at Yale, where he was the director of perinatal research before joining the NIH. His team has made seminal contributions to the diagnosis and treatment of ectopic pregnancy, prenatal diagnosis of congenital abnormalities, prediction and prevention of preterm labor and delivery. In addition, Dr. Romero has been the author of over 1,200 peer-reviewed publications and is the editor-in-chief of Obstetrics, one of the oldest journals in its discipline. He is an elected member of the National Academy of Medicine and a recipient of 18 honorary professorships or doctorates. He's been honored by the national and international professional societies for his medical and scientific contributions, and this has included the Ian Donald Gold Medal from the International Society of Ultrasound in Obstetrics and Gynecology, the Eric Salling Award from the World Association of Perinatal Medicine, the Maternité Prize in Obstetrics awarded by the European Association of Perinatal Medicine. He's also the first clinician to receive the prestigious Asian Award in Medicine from the Asian Foundation of South Korea. Please join me in welcoming Roberto Romero.
Thank you, Dr. Janowitz, Dr. Sadowski. It's a great pleasure to speak to you today. And as I was listening to David, I realized that our presentations, I think, are going to complement each other. So, pregnancy is essential. And when we look at complications of pregnancy, it looks as a very simple discipline. 6 conditions account for 90% of all causes of perinatal morbidity and mortality: premature labor, premature rupture of membranes, preeclampsia, small for gestational age or growth-restricted fetuses, and fetal death. So if you contrast obstetrics with genetics, where thousands of conditions are difficult to understand, this looks simple, and we have made a lot of progress. Yet, when we look at obstetrics in the 21st century and examine where we are in respect to these simple complications of pregnancy, treatment at the time of diagnosis is not effective, prediction of diseases during pregnancy is poor, and prevention has been largely ineffective. Now, having said that, I want to tell you that they are very good news, and I will turn to the good news in the second part of the talk. So why is obstetrical disease so difficult to treat or prevent? I believe that the answer to that is the unique nature of obstetrics disease that makes it different from the one that affects adults and children. Obstetrics is the only discipline in medicine with 2 patients, one of which is invisible. And we have one patient, which I consider the most difficult patient in medicine for reasons that I will explain later. Viviparity requires the deployment of adaptive mechanisms to protect the mother while supporting fetal development. Well, one can think of a successful pregnancy as a great example of a cooperative relationship between the mother and the fetus. And when there is an insult, infection, or ischemia, this results in the emergence of conflicts, and the responses to this conflict at the beginning adaptive and then becoming maladaptive results in what we clinically recognize as what I have called the great obstetrical syndromes. Now, just in building on the theme that David articulated a moment ago, if we think of premature labor in the context of infection, we know that microorganisms can gain access to the amniotic cavity during pregnancy. They can stimulate the immune system to produce pro-inflammatory cytokines and signal the onset of labor. Now, if you view this biological enigma of premature labor, it is easy to understand that in the context of infection, the onset of labor, the onset of premature labor, has survival value for the mother, because in that case, she can maintain reproductive fitness. Of course, it comes with a price, and that is the likelihood of survival for the fetus. Now, the term that we use, my insertion point on this was premature labor, but I have now, on reflecting in obstetrical disorders, I realized that everything that we deal with in obstetrics and gynecology is a syndrome. So here we have the main syndromes in the first trimester of pregnancy: implantation failure, early spontaneous abortion; in the second trimester, late spontaneous abortion, early onset preeclampsia, premature labor, and these are the typical complications that I show you in the first slide that are the main complications of pregnancy. Now, what did we mean when we proposed this term? Well, what we were trying to say is that obstetrical disease is different from the disease in adults in certain respects. First, they have multiple etiologies. Second, they have a preclinical phase during pregnancy that seems long for obstetricians. That there is often a fetal involvement, even though the way we diagnose the conditions is on the basis of maternal symptoms. We say that patient has a premature labor because those are contractions, or that the membranes are ruptured because fluid is leaking. But as I'm going to show you in a few moments, often there is fetal involvement in these symptoms. Then the crucial difference between adult and pediatric disease and that of pregnancy is that the clinical manifestations are adaptive, and this is the case in premature labor, preeclampsia, and so on, and that they result from a unique situation. Viviparity leads to the existence of complex genetic and environmental factors because there are two genomes, the fetal and maternal genome, and two environments as well. Now let me begin with a very simple example of adult medicine to make my case. This is how, if we had a patient 60 years old with a cough for several days or several months due to an insult in the tracheobronchial tree, the way in medicine we'll deal with that is to do a chest X-ray to identify the fundamental problem, in this case pneumonia, in this case pulmonary embolism, here a patient who has cardiac failure and pulmonary edema, or a patient with cancer. And the treatment for each of these conditions will be informed by the cause of the problem. So for pneumonia, we will give antibiotics. For pulmonary embolism, this patient will have heparin or thrombolysis. For pulmonary edema, we'll give them diuretics and chemotherapy for the patient with cancer. And selection of the appropriate treatment is crucial, because if this patient with pneumonia is given chemotherapy, that patient is going to be killed. Similarly, if a patient who has pulmonary embolism and we give him diuretics, the patient is not only not going to improve, but the likelihood of complications is going to increase, because we're going to maximize the likelihood of having further thrombotic events. So in clinical medicine, we have the patient who has a chronic cough. We do a chest X-ray to diagnose the condition, identify the microorganism, and then tailor antibiotics. One of the great successes of medicine in the 20th century. What about obstetrics? Well, this is a patient presenting with premature labor, regular uterine contractions, and what do we do in obstetrics for the last 50 years? We have been administering uterine relaxing agents to colysis in the Utopar advertisement to keep the fetus in the ideal intensive care unit, a metaphor that I think is apt, but for the wrong reason. We have tried to stop uterine contractions in patients with premature labor by giving patients intravenous water, intravenous alcohol, believe it or not, one of the therapies to stop uterine contractions, and then all of these examples. Fundamentally, none of this works it reduces the frequency of contractions. Perhaps it delays delivery for 48 hours. But these are not the magic bullets to transform premature babies into term babies. What kind of treatment is tocolysis? Well, since we began with the analogy of the cough, it is fundamentally Robbie testing with codeine. It is symptomatic treatment because the problem are not the contractions. The problem is what causes the contractions. So what do we do in clinical medicine today? The patient presents with premature labor. We skip the chest X-ray, we skip the understanding of the precise cause of premature labor, and we go straight to symptomatic treatment. In medicine, however, successful treatment is aimed at the cause of illness, not at the symptoms of illness. So now we understand that premature labor is a syndrome that is caused by multiple etiologies, infection being only one of them. And infection is important because it's one that we can diagnose, and we have made inroads by understanding this. But if we do randomized clinical trials, as we have, and I did one of these trials, for patients who have premature labor and intact membranes, patients were randomized to placebo and antibiotics. And of course, we got negative results. And this inspired our professional organizations to say antibiotics should not be used to prolong gestation, which of course, when dealing with all patients in premature labor is correct. But is it accurate to say that no patients with premature labor benefit from antibiotics? Well, clearly, 1 of every 4 preterm deliveries is born to a mother who has intramniotic infection. It is subclinical, so if patients don't have a fever, but is it correct that we should not give antibiotics to patients who have proven intramniotic infection? Well, we know that these infections are present in 25% of the cases. Intramniotic inflammation, 10% will have intramniotic infection. And if we identify this is the equivalent to the chest X-ray, this is the fetal head, amniotic fluid, this is the presence of sludge, we perform an amniocentesis, identify microorganisms, and give antibiotics. That subset of patients benefit from antibiotics. And to test that hypothesis, this study took us 20 years. The presence of bacterial inflammation in amniotic fluid, giving patients antibiotics, and examining whether we have effectively reduced the frequency of inflammation and infection. We now know that we are able in that patient to reduce the frequency of inflammation and infection by 79%, and the overall treatment success, getting patients to term, is 84%. So the resolution of intramniotic infection and inflammation, which we thought, including myself, that it was impossible, it is possible if we identify the right patient. So, but even this has complexity, because the same patient that is coughing, if he were to have this chest X-ray, the treatment will not be penicillin, because the problem is in the upper lobules of the lung, and this is often caused by tuberculosis, and then we need a different antibiotic because penicillin is not going to improve tuberculosis. Well, the same happens in intramniotic infection. The organisms that cause neonatal sepsis and we're obsessed about are not the ones that cause, and all these 3 organisms can cause premature labor. Now, are the multiple etiology concept only relevant for premature labor? Well, here is a case of fetal death from our institution. Infection is known to cause fetal death. In the pre-antibiotic era, syphilis was a leading cause of fetal death, and actually 10% of patients who have untreated syphilis have fetal death. In the post-antibiotic era, and with treatment of syphilis during pregnancy has decreased. But by far, the most common cause of fetal death are vascular lesions, placental vascular lesions or malperfusion, infarctions of the placenta. But even these 2 do not explain all causes of fetal death. In some cases, we have just simply a core accident that has nothing to do with these 2. So the idea that we will predict fetal death with one test, or we will prevent fetal death with one intervention, is really I'm surprised that we still think in this way or we act clinically in this way. It's not a service to pregnant women. The same can be said of preeclampsia. Here is the center of preeclampsia, placental diseases, uteroplacental ischemia, but now we have realized that SARS-CoV-2 is a cause of a syndrome that is indistinguishable from preeclampsia. But there are many other conditions that are accounting for this. So the idea that there is one cause for a set of symptoms in obstetrics is, in my view, untenable. Now, what are the implications that obstetrical disorders are syndromic in nature? Well, there will be no single test, diagnostic, prognostic, or screening. And I think that we need to cure ourselves from the idea there is going to be a single intervention that is going to solve all these problems. The second feature of the great obstetrical syndromes is that we diagnose them largely in the third trimester, but they have a preclinical phase. So here is the 3 trimesters of pregnancy, organogenesis, the silent mid-trimester, and then the typical time when we diagnose most pregnancy complications. But we know, as early as 1973, the classic paper by Norman Gant, that pregnant women who subsequently develop preeclampsia have an abnormal pressure response to angiotensin II at 22 weeks. Moreover, these patients who have an abnormal uterine artery Doppler, a completely asymptomatic finding, are at increased risk for preeclampsia, fetal death, and abruption. And even infection that we consider an acute phenomenon, if we perform amniocentesis, we find infection. These patients, weeks later, go on to develop preterm labor and preterm prom, incidentally completely asymptomatic. So we can have an asymptomatic pathologic process operating for weeks before we develop the obstetrical syndrome. What are the implications of this? We have to realize that when we recognize an obstetrical syndrome, this is late in the evolution of the disorder, and that the insults have occurred early in pregnancy. What are the implications? That even though the diagnosis is late, that tells us there is an early window when it may be possible to identify the patient at risk. And this opens the door for prevention. And I'm going to tell you, at the end of this talk, we have been successful at doing this. Now, the other feature is that these are fetal diseases. This is the estimated fetal weight of a fetus that you can see as decelerated fetal growth. Here, the patient, the mother, develops gestational hypertension, and here, preeclampsia. So it is possible to demonstrate that in a number of obstetrical syndromes, there is impairment of the biology of the fetus before the diagnosis of the obstetrical syndrome. And of course, this is the case in the context of infection, because when there is intramyotic infection, a subset of these fetuses develop fetal infection, a systemic inflammatory response syndrome, and then there is multiple organ involvement, including neural involvement, and this explains why babies who have intramyotic infection and exposure to intramyotic inflammation are more likely to have cerebral palsy. Now, what are the implications of fetal involvement? Even though obstetricians are primarily concerned with the mother, there is a need to evaluate the extent and severity of fetal disease, because a fundamental question when we deal with obstetrics, the most difficult of all medical disciplines, is whether the fetus has sustained injury and whether it is justified to maintain intrauterine stay rather than preterm delivery. Now, these questions are very difficult because the fetus is the most difficult patient in medicine. It doesn't speak to us. We cannot physically examine the fetus. It's virtually inaccessible for treatment. We can do that through the mother, which is an imperfect way to do this. And most frequently, the most frequent treatment, that is cesarean section, often lead to early preterm delivery. Now, at preterm delivery at 28 weeks of gestation, if I ask you to reflect for a moment, what would be is the equivalent with total body immaturity of being admitted to an intensive care unit with multiple trauma. That is what preterm delivery is. So we need to think very carefully on when to employ the cesarean section in a preterm gestation, because the consequences of that intervention can be potentially lethal, and the consequences may have long-lasting implications for the rest of life. Now, to make the point of fetal involvement, to make the point that this is subclinical, I want to show you this picture. I took this picture in 1992. It's an ultrasound of a fetus that has severe fetal growth restriction. And this is the chest of the fetus over here. And this is a fetal heart. Now what you see here is this circle is the aorta. Under normal circumstances, you do not see two jets of blood coming out from the aorta. These two jets represent the arteries that keep us alive. These are the two coronary arteries. If you have blockade of one coronary artery, you have a myocardial infarction. Under normal circumstances, during fetal life, you cannot see these vessels. What is happening is that this baby with severe growth restriction has systemic hypertension, and it's difficult for that fetus to maintain perfusion of the heart. The coronary arteries are maximum vasodilated. Well, we know from the work of David Barker that fetuses that growth restriction are more likely to have myocardial infarctions later on in life as adults. But here is an example, an extreme example of fetal growth restriction at 24 weeks of gestation. This baby with dilated coronary arteries was diagnosed to have a myocardial infarction at birth because of documented by elevated troponin I. So this is the example of something we diagnosed fetal growth restriction in a small baby. If we didn't bother to examine the fetal circulation, we will not know that there is cardiovascular involvement or myocardial infarction, and this is otherwise a silent condition. Now, the clinical manifestations of obstetrical syndrome are adaptive, and if this is my view, if there is a problem with the supply line, the easiest way for nature to deal with that problem is to reduce fetal growth. If that is not enough, nature has devised a second mechanism to deal with this, and this, if there is a compromised supply line, then the placenta sends signals to the maternal circulation to increase systemic blood pressure, just what David described in his talk about preeclampsia. Now, what happens if the insult, if the pathology has nothing to do with the supply line? Well, nature, let's say in the context of infection, there is ascending intrauterine infection, slowing fetal growth, or signaling maternal hypertension is not going to solve the problem of bacteria becoming life-threatening to the mother. The way to solve this problem is by signaling the onset of premature labor in the context of intact or ruptured membranes. Finally, obstetrical syndromes emerge in the context of a unique relationship, genetic and environmental, because there is the maternal and the fetal genome, and there are two environments. And the complexity of disease in obstetric, imagine whole genome association studies to deal with the genetic predisposition of schizophrenia. It needed 40,000 patients in order to elucidate the genetic risk factors. Imagine what is the complexity of maternal and fetal genomes and the interaction of those genomes and the environments. Now, this is a picture of Joseph Valentine, who in 1901 published this paper calling for the need to establish maternity hospitals. And he was the father of what we call pro-maternity care is antenatal care today. And the three goals of pro-maternity care were the prevention of fits or eclampsia, treatment of maternal disease, specifically diabetes and hypertension, because diabetes used to be lethal during pregnancy, and the antenatal identification of what were called monsters in 1901. These are congenital anomalies. Well, prenatal care has been a great success because preeclampsia in developed countries is rare, diabetes rarely kills patients, and prenatal diagnosis is now possible. The frontier of prenatal care in the 21st century is to develop and propose a new taxonomy of obstetrical disorders that is based on the understanding of the causes of each syndrome. It is not premature labor. This name is useless unless that we know what is the cause for the problem, and there is a subset of patients that have a mechanism of disease that can be treated. The second is that it is time that we accept that treatment at the time of diagnosis is largely ineffective, and we need to emphasize prediction. And also, it's time to accept that medical history is not enough. The third is an emphasis of biomarker discovery, and there are hints, which I won't have time to cover today, that the use of omics technique can help us with this. And the last is prediction is only valuable if we can prevent. Now, what are the three challenges to obstetrics? First, each mechanism of disease operating on a particular syndrome affects only 1% of all pregnant patients. If we have a wonderful test that is 99% specific and 99% sensitive, most screen positive tests are going to be false positive. And if you discover the wonderful biomarker with these performing characteristics, we need to accept that this is just a fact of life. And this requires that any intervention must have a large margin of safety for both mother and fetus. And this is the risk that no other discipline in medicine has. Is this impossible? Well, I'm going to tell you two success stories. The first one is that in premature labor, a decline in progesterone action is a mechanism of disease mediated to cervical disease. And now we have a simple method to examine all women in the mid-trimester of pregnancy and to identify those with a short cervix. Among those with a short cervix, if we give them vaginal progesterone, there is a significant decrease in the rate of return delivery from 28 to 36 weeks of gestation, and will reduce the rate of neonatal output. And this is a simple intervention that is cost effective in every study that has been done, and is estimated to save the US healthcare system approximately $500 million a year. Now, does progesterone work in all patients with a history of preterm birth? Of course not. This would be, I don't know how we came with that expectation, but this can only benefit this group of patients because it's not going to help the patients who have intramyotic infection. The second success story, is one of preeclampsia that was considered a prostacyclin deficiency state in which they increased platelet aggregation. And this is a paper that we wrote with Charlie Lockwood many years ago in 1988. And here is aspirin, an intervention to prevent preeclampsia by inhibiting platelet aggregation. Well, this is one trial. I was one of the founding members of the network. This is prevention of preeclampsia with low-dose aspirin in nulliparous women. Negative results. Low-dose aspirin to prevent eclampsia in high-risk women. Negative results. Here is a meta-analysis published in 2007, 31 randomized clinical trials. Aspirin works. But do you know the magnitude of the effect is only 10%? Well, can we do better? The answer is yes. This is work with Capers and Nicolaitis in the first trimester of pregnancy, assessing the mean arterial blood pressure, uterine artery Doppler, and placental growth factor. Identify 90% of women who are going to have early onset preeclampsia. And in a randomized clinical trial that enrolled 26,000 women, because this is what it took to do the pregnant trial to demonstrate the effectiveness of progesterone, we know that aspirin can decrease the rate of early onset preeclampsia and preterm preeclampsia. So, is it impossible to understand that obstetrical symptoms are heterogeneous and multiple mechanisms of disease, and to select in the preclinical phase patients who benefit from intervention? I think that these two examples say that this is not the case, but there are others. So what about the future of prenatal care? I think the first task is to develop a taxonomy of obstetrical syndromes that moves away with the obsession that we are making progress by defining something as premature labor or preeclampsia. This in and itself does not help. We need to bring modern scientific thinking to obstetrics. The second is that we need biomarkers for prediction. The blood pressure cuff, the sphingomanometer, was developed in Italy more than 100 years ago, and we continue to use it to diagnose vascular dysfunction during pregnancy. It's difficult to justify this today. And then we need targeted and rational therapies, and the emphasis is in targeted. There is not going to be an intervention that is going to prevent all fetal death, all preeclampsia, all premature labor. So I would like to end. I hope that this is a positive note. I think that we are making progress. And just as the scientists after the Enlightenment saw that there was a terra incognita and dream of this place, I think the terra incognita of medicine is reproduction. I think that we are poised to make progress in this field. And I believe that we need to have an optimistic view about the need to use prevention that must begin in utero. Now, to end, I wanted to, because David mentioned poetry in his talk, I wanted to end with this. I have used this to illustrate the power of omics techniques. I just show you a bunch of words. They don't mean anything in isolation. This is where we have been, in much of medicine. This is the Shakespeare sonnet that illustrate those words. So I believe with having the application of omic techniques, what David thought about the power of poetry will become a reality. And it will be great if that reality becomes true in obstetrics. Thank you very much for your attention.